thanks again for headaches. Um, Basically two types of headaches, and they're classified that way based on the source of the headache, or the way the headache is caused. So we have tension type headaches and migraine type. Migraines are also more common in women than men. Uh, but for tension type headaches, it's usually mild to moderate, and people say that pulsatile. Okay, they give me 1 minute. Let me see if I can fix the audio thing. It's been cracking since I started the class. Audio better now? Okay, like I said, what's it called? The quality of the network is a bit poor, so you need to bear with the network. But I think the recording should be better off now. The audio should be better off now, right? So just to take us over it again, I said there are two types of headaches. There's tension and migraine type headaches. I said the tension type headaches are the regular headaches that we experience from time to time due to stress, and they are thought to originate largely from. Please mute yourself. So I've muted everyone. If you want to talk, please raise your hands or type in the comment section, okay? In the chat box, right? If you put your questions in the chat box, I will be able to see it and stress, dehydration that triggers the mechanisms all the way from myofascial factors, that's structures around the face, and also peripheral sensitization of pain receptors. Okay. Central mechanisms are also involved, that the the brain, the way the brain is activated is also involved. Now, some of the risk factors in our environment, and we experience mental stress, non-physiologic motor stress, local release of irritants in the face, or combination of all these. Sometimes you can also have referred pain as well, as part of the causes for headache. That you have pain in one joint in the body and it's causing headache. Okay, it's referred. Now, clinical presentations. Okay, sorry about that. So I had talked about the clinical presentation and just ongoing, I wanted to mention that as we talk about treatments for these conditions, I will talk about non-pharmacologic therapies. Non-pharmacologic means non-medication related treatments. Okay, they may includes things like massage, reassurance, biofeedback, and others, but they are non-medicine related. That's you don't give drugs to the patient, okay? And then I will also talk about the medication-based treatment, right? And also give you some pointers about the ones that are most important and others, okay? It's important that I mention to you at this point that the non-pharmacologic therapies are as important as the medication-related treatments because for headache, it presents a lifestyle issue, and in some patients, because of its long standing in them, right, you cannot rely only on medication treatment, medication for treating the pain that they experience. Okay. So for tension type headaches, you have reassurance, counseling, stress management, relaxation training, and biofeedback, right? Including physical therapeutic options like using heat or cold packs. This is very common, especially if you live in a medically underserved area. You'll find that for headaches, they use towels wet with cool water, right, and apply to the skin, to the forehead to reduce the pain sensation and resolve the headache. There's ultrasound, the use of ultrasound waves as well. There's electrical nerve stimulation, which is very important. There is massage, there's acupuncture, which is culturally important. And then trigger point injections and the occipital nerve blocks, right? These also are quite important, even though they are not, there's no there's no clinical evidence to support all of them, but because they are reassuring to the patient, they are often included in treatment. And then, of course, we use simple analgesics, right? Especially those we've talked about in the last class, like NSAIDs. They are the mainstay of treatment for acute headaches, right? You didn't get the clinical presentation part. Okay, we'll go over that later, right? The mainstay of treatment, and of course, the simplest to start with is paracetamol, acetaminophen, right? For acute headaches, acetaminophen is the gold standard, right? It has very few side effects except when abused, and it is even though the dosage may be a bit challenging, right? And patients who have chronic headaches may experience breakthrough pain in the morning if they use paracetamol at night. That's because the dosing frequency for acetaminophen is 6 hourly, right? And between the time patients sleep and when they wake up, it will likely be about 8 hours. So the last 2 hours of their sleep, they may be rudely woken up with, a headache, the pain from the headache. So usually for patients who may have chronic head pain like that, you may want to look at diclofenac or ibuprofen that have longer, half-life and will stay longer and cover the patients for longer, right? Those are important differences to note when you're dosing the patient. Of course, high-dose NSAIDs and combination of aspirin or acetaminophen with butalbital or rarely codeine are effective options, right? Avoid the use of butalbital is a barbiturate, right? It's often used in combination with NSAIDs in the treatment of serious headache when headache becomes a bit severe, right? And the simple analgesics can no longer handle it, right? So usually we say avoid the use of the barbiturate and codeine combinations when possible because you do not want to expose the patient to the side effects. Codeine, for example, side effects include the feeling of euphoria, the likely addiction that may come off from codeine exposure, and then the GI disturbance, what's it called? The patient may experience slowing of GI movement, which will lead to constipation, right? When they are exposed to opioids like codeine, right? And then the other challenge with butalbital is that it makes patients drowsy and tolerance can develop within 1 week, right? So you always want to avoid. Then another challenge with butalbital is because it's a barbiturate. If used in the elderly, you have increased falls, right? The elderly can fall down either from hypotension or from missed steps, right? So those are very important things to note. So for acute headaches, we do not use high-dose NSAIDs. Don't use combination with barbiturates or codeine, right? Give acute medication for episodic headaches no more often than 3 days, right? No more often than 3 days. If there is a need to use medicines exceeding this, there is a treatment ladder, right, that you consult. If you're using combination analgesics, no more than 9 days or 15 days if you're just using the NSAIDs. If it exceeds 15 days, then I think you need to you need to refer the patient, because what you will end up having is there's something called when patients use NSAIDs for long to treat headaches, there's something called rebound headache or NSAID related headache, where the medicine you're using to treat the headache worsens the headache itself. Usually this happens after about 2 weeks using NSAIDs, for the same headache. If that's the point, then you're going to start, that's your treatment is going to bring on the onset of the chronic tension type headache, which you don't want. So once you've treated for 2 weeks, you give the patient a break, move them on to non-pharmacologic therapy for a little while, and then you can switch them back again to NSAID treatment. There's no evidence to support the use of muscle relaxants in tension type headaches. It's best that we 1 minute. Yes, Temitope.
Good afternoon, sir. I want to confirm acetaminophen is not an NSAID, right?
Paracetamol.
Yes, I know it's paracetamol. I want to confirm it's not an NSAID, right?
Yes, we do not call it an NSAID because it does not have the anti-inflammatory action.
Okay, sir. And then about the Babi butal combination.
Yes.
I want to confirm if the difference between the 9 days and the one that is
3
for
days.
3 days. Yes, I want
The
to
one for
confirm.
3 days is the combination with opioid or barbiturate.
Or barbiturate. Okay, sir. But if the
The
combination
one
is
for
just
9 days is combination of NSAIDs. For example, combinations containing diclofenac and paracetamol, or ibuprofen and paracetamol, or ibuprofen and what's this other one that's commonly used? There's another one in the mix as well, right? So if you're combining two or more NSAIDs together, not more than 9 days. If you're combining with barbiturate or combining with codeine, not more than 3 days. Is it clear? Okay, I hope that's clear. All right. So preventive treatment if headache frequency is more than 2 per week. So if the patient has to treat headaches twice a week, right? What we mean by 2 episodes a week is at least the patient has headache-free period of about 24 hours. It means that the last episode has completely resolved. If another one starts again after 24 hours, then you're treating a new headache. So if that patient has more than 2 episodes in a week, then it's important that we begin to consider preventive therapy, right? So you need to first identify what is causing the headache and initiate prevention, right? More than 2 per week. If the duration is longer than 3 to 4 hours, or the severity results in medication overuse or substantial disability. For example, some people have headaches and they cannot do any work, or they have headaches, they are vomiting, they are dehydrated, right? In that case, you need to consider preventive treatments, right? Tricyclic antidepressants, in some practices, they are used off-label, right? But they are most effective for prophylaxis of tension headache, right? So instead of using them to treat, it's preferable to use tricyclic antidepressants. I think you've covered tricyclic antidepressants in your neuropharmacology, right? I think that should be in 400 or 300 level, right? So these are agents that are centrally acting. They act in the brain, right? So TCAs are used most often for prophylaxis of tension headache, but in the event of contraindication or severe side effects to tricyclic antidepressants, venlafaxine, mirtazapine, gabapentin, most commonly used here in Nigeria because of its affordability. Gabapentin and topiramate may also be effective, right? So in Nigeria, our main options in prevention are TCAs and gabapentin, mainly, right, because of affordability. Now, let's quickly talk about migraine headaches, and this will be a little bit more, a bit broader, and we'll dig in a little deeper because this is a real cause of morbidity. When we look at the I think when we look at the epidemiology, I think you'll see what I'm talking about. Migraine is common recurrent primary headache of moderate to severe intensity. There's nothing like mild headache, mild migraine. Migraine is always severe, right? People who experience migraines report pulsation. It's as if something is banging in their head, like someone is clapping cymbals or beating drums. Those are some of the descriptions that are given, when people are talking about their headaches. And then, of course, it's usually they either say it's localized to one side or it's pulsing in one side, right? And then for migraine, right, it interferes with normal functioning and is associated with GI, neurologic, and autonomic symptoms, right? In migraine with aura, that's the one where patients can predict that they will have an episode of migraine. Focal neurologic symptoms precede or accompany the attack. The focal neurologic symptoms are those premonitions the patient has are the focal neurologic symptoms. So, for example, some people become colorblind just before their headache starts, right? It's part of the pathway for their own pathophysiology. In some cases, patients may start vomiting, or they may just have this impending sensation that something bad is going to happen, right? They just have this sensation at the back of their mind that something bad is going to happen. Or sometimes they may immediately associate it with their headache. I'm going to have my headache soon. I'm going to have my headache soon, right? So those happen as a part of the disease progression, right? And what's the pathophysiology of migraines? First is the activation of trigeminal sensory nerves, right? Leading to vasodilation of dural blood vessels. Now, the vasodilation of the dural blood vessels in the brain is the main the main cause of the pain and the perception of pain that patients the main cause of the pain, right? Since they activate the release of the pain transmitters within the brain, right? So you have specific population of serotonin receptors involved in the pathophysiology to help propagate the pain. And you find that ergot alkaloids and tryptan derivatives are agonists of vascular and neuronal 5-HT1 receptors, resulting in vasoconstriction. So once ergot alkaloids and tryptans are used, they cause vasoconstriction of the dural blood vessels and inhibit the vasoactive neuropeptide released when blood vessels dilate. Okay, this is very important for your understanding, right? Because understanding how the whole cascade of migraines starts is important for the treatment, because it's a lifelong illness, and sometimes with severe morbidity. I've had a patient before that we cared for in conjunction with neurology department in Lut, who was practically bedridden for up to 1/3 of the year because of migraines, right? So it's really causes severe morbidity for patients, and it's important that if you understand how it is formed, then you really understand why the treatment is so difficult. Migraine headaches are characterized by recurring episodes of throbbing head pain, frequently unilateral. That's why I said frequently patients talk about their headaches only in one part of their head, right? About 12 to, in fact, a lot of migraineurs, right, have the premonitory symptoms. That's they have some symptoms in the hours of days before their headache onset, right? And then neurologic symptoms are most common. For example, sound. They hear sounds, right? or are afraid to stay in places where people are talking. Photophobia, that's afraid of light, right? Hyperosmia, they kind of breathe more deeply, right? And then there's difficulty concentrating. And this is one of the reasons why they have difficulty with functioning, right? So these are the most common neurologic symptoms. But of course, psychologically, there are also symptoms like anxiety, depression, euphoria, irritability, very common irritability. They become very, very sharp on people that are around them. They scream at you for no reason. They, I mean, the things you used to do that they would laugh, they become very moody, depressed, and restless, right? And then there are also autonomic symptoms as well, like polyuria, diarrhea, and constipation, right? And then, of course, they may have some constitutional, which is like gross body effects as well, like stiff neck, yawning all through the day, thirst, food cravings, and anorexia. In some people, rather than having food cravings, they just don't eat anything at all, right? These are some of the symptoms that occur with migraine, right? About a fourth of migraineurs experience aura, and this evolves over 5 to 20 minutes, lasts less than 60 minutes, right? Remember that premonitory symptoms is what we describe that happens in hours or days before headache onset, and those that happen shortly before headache onset, between 5 to 20 minutes, less than 60 minutes to the headache, right? Those are called aura, right? It can be visual, it can be auditory, right? So visual auras can include both positive features like scintillations, photopsia, tachypsia, and fortification spectrum, and it could be negative like scotoma and hemanopsia, right? For the sensory and the motor symptoms, such as paresthesias or numbness of the arms and face, right? There's also dysphasia or aphasia, there's weakness, hemiparesis, where the person can't move some part of their body, may also occur. But of course, hemiparesis disappears as soon as the headache starts, right? So all of these auras disappear once the headache starts. Migraine headaches may occur at any time, but usually in the early morning. And the pain is usually, I mean, the patient can describe the pain, right? Peaks in intensity and lasts between 4 to 72 hours, typically in the front of the head, moderate to severe. Yes. So thank you for this question. Amanda says, can you stop a migraine from happening by targeting it during the aura period? So it's best to prevent a migraine in the 24 to 48 hours before it happens, right? By the time it gets into the aura period, most of the preventers will be less effective, but can still reduce the intensity and the duration of the migraine, right? But we're not yet there, okay? So once we get there, I'll signal that your question has been answered, right? Now, once the headache wanes, resolution phase, where the person is exhausted, feels a lot of lethargy, malaise, and irritability starts, right? And the best way to actually diagnose migraine is a comprehensive medication, headache history, right? And then because it's heritable, you also need to find out if there's a family history of this. Like I said, these are just important these diagnosis parameters are not really important. I'm giving you this background because for some of you practicing in the community, you'll see a lot of this, and then you can signpost them to the appropriate care, right, that they need. If migraines happen after the age of 50, it's a pointer that this person may have a problem in the brain. It could include things like a mass, a cerebrovascular disease, or even temporal arthritis, right? So it's important that if it starts after the age of 50, the person should be referred for, secondary evaluation as well, right? Now, in terms of treatment for migraines are divided into two. The goal of treatment is to achieve consistent, rapid headache relief with minimal adverse effects. Please, I need you to keep this at the back of your mind. Goals of treatment, there is no way. I mean, because you're going to become pharmacists, right? I expect that the goal of treatment for disease conditions are going to be like at the back of your mind, because both the patient and the physician are going to rely on you a lot to guide them. If you don't have those goals of treatment at the back of your mind, then you will not be able to order, you won't be able to guide the treatment of the migraineur appropriately. So it's important that you learn this by heart. And symptom recurrence. Sorry, my internet is being choppy again. Right. So please pay attention to the goals of treatment. You want to relieve the headache, but you want to do it with as few adverse effects as possible. Right? I could not do anything for um, bedridden for about a third of the year. So okay, so you can make a lot of changes, to your patient's quality of life by paying attention to their treatment and fitting their treatment to goals, right? So that you help them avoid disability, emotional distress, so that they can resume normal daily activities, right? So ideally, patients should be able to manage their headaches effectively without having to come to the hospital. Okay, the goal usually is that we want the migraineur, right, between their regular visits to the hospital to not need to come to the hospital at all. They should be able to manage their preventers, their relievers themselves. So it requires a lot of education. You have to educate the patient. You have to teach them to manage their doses. And some of those drugs are very addictive. So you need to be able to help them and also ensure that they do not get side effects from the medicines that they will be using. Okay. Also want to ensure we limit acute migraine therapies to fewer than 10 days per month to avoid development of medication misuse headaches, right? Like I mentioned, we have two ways we kind of manage here, non-pharmacologic and pharmacologic. Let me quickly go on. Okay, so first let's talk about non-pharmacologic. The famous ice pack, right? apply ice to the head. Usually it's dry ice that's effective. So you can either ask them to put the ice in a nylon, in a, what are those bags called? Those resealable nylon bags. I think they're called track bags or something, right? So they just put the ice blocks inside, or they can even use a regular nylon. I think those ones called Santana, right? All they need to do is put the ice inside the bag. You should be able to see the slides now. It's sharing. Yes, Ziploc bags. Thank you, Ziploc. Thank you. So they can put them in Ziploc, but of course, if they don't have Ziploc, they can put them in regular nylon, tie it up, they put a towel around it, and then apply to the head, right? And that helps as well. Also recommend sleep, rest, especially in a quiet, dark environment. And then you need to help them identify their triggers as well. And identification of triggers is best if you tell them to keep a headache diary. There's something called the headache diary. Means that every time they have a premonition, they have an aura, they write it down. And then they document their day so that you can easily identify when you're working with them. Is there migraine? Is it triggered by food? Is it triggered by the environment? Some people have more headaches when they come into Lagos and fewer headaches when they're in Abuja. There are people who have more headaches when they're in Lagos, fewer headaches when they're in South Africa, right? So you need to help them identify if it's environment-based or it is food triggered or it's behavioral. For example, it's related to stress from work, it's related to hey, now wow. So it seems like the network providers don't want us to do this lecture, but we will do it. So apologies again for the network. Please check it again. You should be able to see my screen now. You should be able to see my screen now. I have shared my screen again. So I'm resharing it again, just in case. Oh. Is everyone seeing my screen? Okay, awesome. Okay, so you asked that I go over the headache diary again. Like I said, the headache diary is a simple one. It's just a diary where the patient records their activities, their environments, where they are, what they're doing, and how it's contributing to their general health, right? It may not be accurate, but what is important is that they document something, because as they are documenting and you are, checking up their headache diaries regularly, every time they show up in the clinic, you check their headache diary, next time they come to the clinic, you check their headache diary again. You will begin to narrow down their triggers. You identify and narrow down their triggers, and you are able to help them resolve the problems around their health. Okay, so that's very important. So moving on, I said behavioral interventions are very important, right? It helps every patient. So whether the patient needs drug therapy or doesn't, behavioral interventions ensure that, right, the patient is not indirectly contributing to the problem of the headache. Okay, so they include relaxation therapy, teaching the patient how to relax. Is not cognitive. Relaxing is not cognitive. There are some people who don't know how to relax. Some people are hyperactive. Some people they're used to stressful environments, and some other people just don't know what puts them into a relaxation. What helps their body to relax. So you need to take them through relaxation therapy. Most times it's not you, right? You need to refer them for that service. So they go through relaxation therapy. Biofeedback is another process where a consultant helps them understand how their migraines may be contributed to by the kind of diet and other things that they're putting into their body, right? And then cognitive therapy is where you help a person identify where mental stress may be contributing and the techniques to avoid getting into those mental fatigue that they are used to getting into. Okay. Now, this is the treatment cascade for acute migraines. First, we start with diagnosis, right? It is not right to treat any migraine without a medical diagnosis of migraines, because you may just be treating a chronic tension type headache without knowing what you're doing, right? And that can result into serious harm for the patient. So once there's a diagnosis of migraine by the physician has diagnosed that, okay, this patient is having acute migraine, right? First is patient education. Remember, I mentioned that one of the most important interventions is educating the patient. So you give them a general wellness program and how to avoid trigger factors. So as part of this is where you implement your headache diary, right? Where you give them a diary or you ask them to buy a diary, and then of course they pay for it, right? And then they document everything. They document all that's surrounding that headache process. So if they feel better because they did one activity or they drank chamomile tea, they record it in their diary. If they went to your patient maybe is an actor and acts a very high intense scene and comes back with a headache, they record that this was what happened before my headache started, this was what I ate before my headache started. All of that they report to you, right? And so that forms part of the patient education, because you're pointing them in the direction of identifying their trigger factors at this point. Right? So the next point is to assess headache severity and degree of associated disability. Now, these points are done in cognizance with the physician as well, right? So you can use either a visual scale or tell them from 1 to 10, 10 being the worst kind of pain you can feel in this world. How intense or how severe is the pain you feel. From the best day, from your most productive day, because you have to assess disability as well. From your most productive day where you're feeling hale and hearty, you're able to meet all your goals, to the worst day, you're stuck in bed, you're vomiting, you feel miserable, you feel terrible. Rates from 0 to 10, right? So you assess their disability as well. And then at this point, you begin to consider prophylactic pharmacotherapy if, for example, severity is high and there is associated disability. Now, if the headache is associated with severe nausea or vomiting, then you can pre-treat the patient with antiemetic, right? Those are drugs that prevent emesis or vomiting. Consider use of suppositories, very important, because if they swallow medicines, they can as well vomit them. And parenteral solutions are not advised because of safety. So we usually look at suppositories or intranasal formulations. Suppositories like promethazine, rectal suppository, right, are important. There are intranasal formulations of antiemetics, even though not very common here in Nigeria, right? Now, once you're from this point, if you identify that there's nausea involved, right, depending on the type of symptom, like I mentioned earlier on, there's nothing mild about acute migraine. So usually it's actually moderate symptoms and then severe symptoms. So for people with moderate symptoms, you can look at simple analgesics, but usually patients complain that they are inadequate. So most times from diagnosis of moderate symptoms, you move to combination analgesics. But if you achieve adequate response here, then it's always best to reduce the dose until you can go back to just one agent that is adequate, okay? And once that is done, then you continue the patient at that level, right, until their migraine resolves, and then you go for prophylactic when there's resolution, right? But if there are severe symptoms, then you come down the scale. There are two options you can look at. You can look at triptans, for example, sumatriptan, or you can look at the dihydroergotamines or ergotamine tartrates, ergot, right? These have serious side effects. So usually, first line, you want to try sumatriptan first before looking at ergot alkaloids, right? And if there's inadequate response, then you look at combination of sumatriptan and one NSAID. If that doesn't work, then you look at sumatriptan and two NSAIDs. At the worst, combinations of these two can be considered under specialists, but it's not commonly required. So that's the treatment algorithm for acute migraines, right? And some of the analgesics that are used as indicated here: aspirin, diclofenac, ketorolac, naproxen, tofenamic, or combinations of acetaminophen and caffeine, right? The NSAIDs appear to prevent neurogenically mediated inflammation in TGV, that's the trigeminovascular system, by inhibiting prostaglandin synthesis. Of course, this is the mechanism of action we described last week. So this is just a pointer to how NSAIDs help reduce the vasodilation that happens in the brain to reduce the swelling, right? In general, NSAIDs with long half-life are preferred so that they are, there's less frequent dosing. And then rectal suppositories can also be given for patients with severe nausea and vomiting. So if your patient has really serious... Yes, I said you can give so I think Tim Tokwe is asking that from the treatment algorithm that I said that we can give prophylactic treatment if the severity is high. That's after resolution of that ongoing migraine. Okay, so immediately there is a migraine. Remember what I mentioned now. Immediately there is a migraine, right? You are going straight to triptans or ergot alkaloids. But once that is resolved, once the treatment is aborted, then you consider prophylactic. But remember that we're talking about acute migraine at this point. And the point about acute migraine is that it's just happened once. It doesn't repeat again, right? But if it does, then we need to consider prophylactic pharmacotherapy. Okay. Good. So these are, these are just short notes around the pharmacologic agents. This is not going again. Okay. These are just short notes around pharmacologic agents that can be used. These are also notes about ergot alkaloids. They're useful for moderate to severe migraine headaches, non-selective, so they constrict intracranial blood vessels and inhibit development of neurogenic inflammation in TGV, right? Venous and arterial constriction occurs in this case, and they have activity at dopaminergic receptor sites as well. There's ergot tartrate and dihydroergotamine, right? Ergot tartrate is available for oral, sublingual, and rectal administration. DHE is intranasal and parenteral. Okay. Nausea and vomiting are common with ergot derivatives. That's why usually first line is sumatriptans. Don't use both of them within 24 hours of each other, because you can cause peripheral ischemia, right? Which is potentiation of ergot action. Remember that we said that venous and arterial constriction occurs. In the extremities, you have very tiny arteries and veins, right? So if there's ergotism, that's generalized vasoconstriction, then you're going to have areas of your body, of the patient's body, that will not be supplied by blood. That's a very serious side effect, right? The patient will feel cold, numb, and extreme pains at the extremities. This will lead to gangrene. And of course, once there's gangrene, most of us know that the next step is amputation, right? It's headache the person is bringing. Now you have taken the person to amputation, right? So we need to be very, very careful. If you're moving a patient from ergot to sumatriptans, ensure that there is a washout period of more than 24 hours. Usually we look at 48 hours, right? Contraindications for this is, don't use ergot alkaloids in patients with renal and hepatic failure, in coronary, cerebral, or perivascular disease. Of course, because like we said, it causes venous and arterial constriction, and it is non-selective, right? So it causes it through the entire body. So, I mean, there are a lot of issues with using ergot alkaloids, and so sumatriptans are more, readily used, and they are selective agonists of 5-HT1B and 1D receptors, right? So you have relief of headaches from normalization of dilated intracranial arteries, inhibition of vasoactive peptides, and then the inhibition of transmission through second-order neurons ascending to the thalamus, right? So this is one of the reasons why triptans are like godsend, okay? Especially sumatriptan. See, I don't know of any other medicine that is, even though it's a bit addictive, right? But when properly dosed and the patient is well educated, sumatriptans they're like a breath of fresh air for most patients with migraines, right? And then second generation triptans have higher oral bioavailability and longer half-lives than sumatriptan. But of course, sumatriptan is the one that is cost effective here in Nigeria. So, I mean, that's what we still use a lot of. But then there's no clinical trial that has shown that that has compared them for relative efficacy so far. So we're still, I mean, the jury is still out on whether sumatriptan is the best or the other ones are the best since sliced bread, right? So lack of response to one triptan does not mean that another one is not effective, right? So if sumatriptan is not effective, move your patient to another triptan that is available, right? It could be the new generation triptans. Use them cautiously in patients at risk for unrecognized coronary artery disease. So if you start out your patient on sumatriptan, then you have to do cardiovascular assessment regularly. Our main concern are postmenopausal women, men over the age of 40, and patients with uncontrolled risk factors like hyperlipidemia, hypertension, uncontrolled hypertension, diabetes, right? So it's important. Also, the first dose, the patient will take it in front of you in the pharmacy, right? If the doctor has not administered it to the patient in their doctor's office, right? Once you are dispensing sumatriptan, you give the patient a seat. So he will use it in front of you, and then you monitor them for about an hour to 2, right, before you let them go home, right, to continue treatment. Opioids, of course, you are very conversant with opioids, so I don't think we need to go over that. Since you'll get the notes as well, you can read up on that too. Prophylaxis. Let's quickly look at prophylaxis of migraines, right? If your patient meets the criteria for prophylactic pharmacotherapy, right, there are a couple of steps in how you look at, in a couple of steps in how you decide which medicine you use for prophylaxis. Now, if you remember, I mentioned earlier on that here in Nigeria, right, our most commonly available, affordable preventives are TCAs and what's the other one again? Tricyclic antidepressants, and what is your name? Oh, Lord have mercy. Where is that thing? Gabapentin. Thank you. See, you guys are very attentive. Thank you very much, right? Gabapentin, right? So, moving on. Okay. So those are the preventives that are most commonly available here in Nigeria that we use, right? Now, even though this classification is important, just keep at the back of your mind that in most cases, our patients usually just go on either of TCAs, and if TCAs are not tolerated, they go on gabapentin or gabapentin and TCAs, right? So if the patient meets criteria for prophylactic pharmacotherapy, first you see, if headaches recur in a predictable pattern, for example, if it is related to menstruation, which is very common, right? You ask the patient to start an NSAID a few hours before or a week before when their menstrual cycle is expected to start. So this is where there is a predictable pattern, because you cannot just tell somebody to be using NSAIDs on and on without end, right? So we use this when there's a predictable pattern, because we can predict, okay, start it now, stop it, right? But if it is not predictable, then we do not involve our NSAID, right? Low dose triptans can also be used, right? In this case. But if it is ineffective, right, the patient is healthy, or there's comorbid hypertension or angina, right, we're looking at, remember that our main drugs of treatment both affect vasoconstriction, but one is more selective than the other, right? This is why we're looking at cardiovascular events as well, right? Comorbid hypertension or angina. So if the person has hypertension, if it is controlled, then you can look at including beta-adrenergic antagonists, right? For example, verapamil. Verapamil is this is one I have seen that has been used successfully in a patient with hypertension and migraine, a male patient with hypertension and migraine. I have seen verapamil used clinically, right, in preventing because verapamil is both useful for his heart condition and as well as for his headaches as well, right? This reduced the occurrence of his headaches by a lot. And it also reduced severity of, the migraines when they finally occur, right? On the other hand, if this is ineffective, right, and the patient also has depression or insomnia, right? If there is depression or insomnia, you add tricyclic antidepressants, right? If the comorbidity is a seizure disorder or bipolar illness, right? An anticonvulsant is included, right? In cases where these agents are ineffective, then consider combination therapy, right? But it's always important that if you've walked down this track and you've reached here, then you refer the patient to a headache specialist. We have headache specialists in LUT, so it's important that you refer them at that point. Also, note that for people with, so it's in people with comorbid, for people with comorbid seizure disorders or bipolar illness, if you've tried an anticonvulsant and it's ineffective, then you try beta-adrenergic antagonist. Like I said, verapamil is what I have seen used efficiently here in Nigeria. And verapamil is also very cheap. The cost is comparable to most antihypertensives. I think it ranges from about 450 to maybe about 1,000 naira for 2 weeks supply. So that's still affordable for most patients. And if that is ineffective, then of course, anticonvulsants, you can have gabapentin here, right? So if this is ineffective, then change to verapamil. And then if that's ineffective as well, in the case where migraine occurs in an hypertensive patient, will the headache still be referred to as a primary headache or is it secondary? So migraines are usually primary. I have not seen, even in patients where it was secondary to, for example, some patients' migraines were activated by hormonal differentiation during menarche, right? Some people's migraine, started during menarche. In such patients, they even though you may say it is secondary, but then it is treated as a primary headache. The same thing as we're saying that if a headache starts in a patient after the age of 50, then the patient needs to be evaluated for a mass and other things, right? But migraines are usually primary in nature. So you always treat the migraine as if it were independent of other conditions. So there's a goal of managing that migraine, but it's important to also manage other comorbidities as well. It's similar to when you're treating diabetes in a hypertensive patient. Even though the diabetes is secondary to the hypertension, but treating the hypertension does not take care of the diabetes. It does not, right? Even though it was secondary in causation, but it does not, treating the hypertension does not reverse the diabetes. I hope that's clear. Similarly, too, there is diabetes secondary to tuberculosis, right? So it's important to have that at the back of your mind. So some of the questions I'm responding to are in the chat. So someone who's just following the slides, I'm saying to the class that I'm responding to comments that are showing up in the chat area as I am talking as well, so that you don't feel like, oh, where are all these questions coming from, right? So somebody says again, Hafi says, For patients already on drugs for depression, convulsion, or hypertension before diagnosis of the migraine, is it necessary to combine both treatments, or is one going to be dropped? Like I said, you're treating, but there's something called a compelling indication, right? And that's what we are looking at on these slides right now, compelling indications. If the person has comorbid hypertension, the prophylaxis of choice is verapamil. If the person has depression or insomnia, the prophylaxis of choice is a tricyclic antidepressant, right? So it contributes both to their primary condition and to their comorbid condition. I hope that's clear. So that's with prophylaxis, and then we'll talk about a couple of medicines as well and how they help with prophylaxis of migraines. For beta-adrenergic antagonists, you have propranolol, timolol, metoprolol. But remember, like I said, verapamil has been, even though it's an atypical agent, but it's what I have seen in practice that has been well tolerated, right? For antidepressants, amitriptyline is the most commonly used tricyclic antidepressant for prophylaxis of migraines. Evening doses are preferred because of sedation. It can cause increased appetite and weight gain. So helping the patient ease into understanding their appetite, using vegetables, eating more fruits and vegetables can help with reducing the weight gain observed. I think a very important pop culture icon that we can point to is Kanye West. When he started on his antidepressants, you will notice that he gained a lot of weight, and then he started working out, and it seemed like the weight wasn't going down, right? So that's a very important side effect that a lot of patients may complain about. So you have to reassure them and help them walk through those challenges. Then orthostatic hypotension. So you have to, you have to encourage them when they want to stand up. They just don't stand up suddenly. If not, they'll meet themselves on the floor. They would have fainted, right? Anticonvulsants, valproic acid, divalproic sodium, right? And topiramate are useful. Even though, like we said, gabapentin is the most commonly used here. Valproic acid is a bit expensive in our dear country, Nigeria. So gabapentin is most commonly used. Of course, NSAIDs, we can't overflog NSAIDs, right? Well, that's about it for now. How do you evaluate therapeutic outcomes for prophylaxis? This is where your headache diary comes in again. As they note the frequency, the intensity, and duration of headaches, you also use their notes, compare with what they say when they come to the clinic, right? To be sure that you're on firm grounds and that you are helping the patient as you should. Then you monitor how often they are taking abortive therapy, the sumatriptans or the ergot alkaloids, right? And if they need any other prescription medicines for side effects. So we are always watching for side effects, always, because they are taking lots of medications. Some of those medications have very serious side effects as well. Now, document the patterns of use for the abortive medications, but you cannot have a complete picture if your patient is not even willing to keep a headache diary. So it's very important. A headache diary is central to a pharmacist's management of the patient's headache. So it's important that you note that. Can a medication be used exactly for its side effect? Yes, it's called off-label use, and commonly it is used by what are they called? Specialists. Okay, used by specialists. So I think with that, we've run the course for treatment of migraines. Remember that what differentiates acute from chronic is the fact that there is a cycle of migraine starting, resolving, and then starting again, resolving and starting again, resolving and starting again, right? So we look at prophylactic pharmacotherapy in the case of chronic migraines so that we break that cycle of repetition and debilitation. Amanda says, can holistic approaches to these headaches work? Amanda, what do you mean by holistic? I think we've been holistic enough by saying that there's non-pharmacological and pharmacological. And under our pharmacological, we've not only talked about abortive medicines, we've talked about prophylaxis as well, right? So what do you mean by holistic again? Do you mean including agbo and their cousins? Because if that is what you mean, then we've already covered that. I know. Holistic. The fact that they are herbs does not mean they are holistic. You are pharmacists too. All medicines have side effects. Don't join these people to be saying herbs don't have side effects. They are holistic. Please, you are pharmacists. You are pharmacy students. Don't be joining the Gbogbo Niche holistic everybody. Right? Your recommendations should be based on science, on what we find to be true in clinical practice, not based on our forefathers used to do this. It's not true. A lot of our forefathers died of very simple diseases that they could not even take care of, right? So how are herbs and other things useful in the treatment of migraines? One, as infused teas, chamomile teas and green teas may be helpful in reducing severity and improving stress-related headaches. Okay, St. John's wort and St. John's wort may also be helpful with headaches related to hormonal fluctuations, right? But it's important to note that these additions, these supplementations cannot replace the clinically validated treatments that we have. They can support your patients, but they should not replace what we know that works. Okay? So please always keep that at the back of your mind. That the one that is holistic is the one that we have evidence to support its use, not the one that, we refer to ancient wisdoms, but have no true measure of their effects on the patient's health. A lot of the herbs that we also use, a number of them have hepatotoxicities, and a number of them are also not properly quantified in their clinical effects. Okay, so it's important that we note that some of these are you said I mentioned sexual activity as a trigger for migraine. Me, Happy. When did I mention that? It's in your mind that you had sexual activity as a trigger for migraine. No? Even though that should be true. It's on my slide. Okay. Oh, behavioral. Yes. Okay. So it can. but it's related to behavior. Okay. Now, intense sexual activity can trigger muscular stress. Okay. From intense sexual activity to muscular stress and fatigue, those can predispose someone to a migraine activity. But it does not mean that having sex leads to migraines. Okay. It's intense sexual activity or prolonged sexual activity when the person is already stressed. That is what leads to activating the migraine cascade. Another very important thing too that I should mention, it may look very trivial, but it's very important. Emotional, very stressful emotional events like a heartbreak can lead to heartbreak physiological cascade leading to a migraine as well. Okay, so from the emotional distress that the person suffers, it can lead to sudden vasodilation. It can trigger vasodilation in the brain as well, leading to that cascade for migraines. Okay, so hormones also have a role to play, right, in causing migraines as well. But those are factors and triggers. That's why it's important that you make sure that your patient keeps a headache diary. With keeping a headache diary comes those benefits of identifying that, this is what causes it for this person. Also, if you find that your patient is triggered by sexual activity, it's not that you will counsel them to avoid sexual activity. It's that you help them walk through what triggers it. It could be that it could be related to trauma, right, that they've suffered in the past, or could be related to their desire for intense sexual activity rather than a graded sexual response, right? So helping your patients walk through these problems and adapt to their lifestyle is important. And I hope that has been taken by everybody. So any other questions relating to headaches, migraines? Tomorrow morning, please let's do a 30 minutes so we round up on my part. But tomorrow morning's lecture will be physical, so I'll be in your class and we'll just quickly run over pain and nociception, and then we'll round up our class there. I should have taken it before this one, but I thought this was more critical to get over, right? So in the absence of any questions, the foods that trigger migraine, is there something they have in common? Yes. A lot of them are foods containing, or foods that contain precursors for serotonin. A lot of them are foods containing precursors for serotonin. So that's tomorrow. I will ask you to give me some examples of foods in that class. So I hope you check that up and then you give me feedback tomorrow morning. In the absence of any other questions or suggestions, I want to say thank you to everyone in the class. Have a pleasant day ahead. Bye.